Hi, it's Matthew Holt with the Healthcare Blog, back with another chat and demo and our THC Spotlight. And this is with Justin Schrager. Justin is the founder and the chief medical officer of Vital, Vital IO. You'll find them on the web. Vital is in the business of, I call it patient navigation and awareness while they're in the hospital, and in actually during care. This is something that I think people haven't thought a lot about, but over the years, you get into a hospital, you get in an emergency room, you get in an inpatient room, no one really knows what's going on. But there's a lot of data in the hospital, in the ER and in the ED, help which should be able to help you, and Vital's in the business of servicing that and helping people out. So I hope I've got that roughly right, Justin. You can correct me if that's not entirely what you guys do. I know you do a bit more than that, but we're going to see some examples of that. But thanks for coming on the blog.
Thanks for having me. Yep, that's basically what we do. We try and make things easier for patients to understand while they're in the hospital.
So let's start with the basics. How long have you guys been doing this?
Aaron and I co-founded the company about 8.5 years ago. We're a venture-backed company, post Series B, and made it through the pandemic, and we've come out doing this for about 8.5 years.
So what is the so ignore prior to 8.5 years, prior to you guys doing this now? What is the typical experience of a patient either going to the ER or being admitted to the hospital in terms of understanding what's going on? And why is there a problem? Why do they need you?
Yeah, I mean, that's a good point. So the problem we solve is communication. We try to improve the sensation of depersonalization, being forgotten about, not understanding what's going on, feeling talked down to, all the things that people complain about in medicine. And I think they're true to some extent. I'm an ER doctor. I've been working in the ER for a long time. I still do. I still practice. And the things that I've noticed, especially during the pandemic and post-pandemic, is that um, people have a different need for information. They experience it in like every other consumer aspect of their life, like whether it's buying things on the internet, ordering food. And it's just the digital consumer nowadays is different, more demanding, and less compromising when it comes to lack of information. So really, it was spurred on by the pandemic. But if you're a patient and you check into the ER nowadays, more often than not, you're going to spend a good amount of time in the waiting room, which is a bit of a black hole. You don't really have information on what's going on behind the scenes, why you're waiting, how long you have to wait, why the guy who checked in after you gets to go before you. Hey, they took some vials of blood from me after I got triaged. What happened with those vials of blood? What
Right.
tests are those? Like, just it's not a place that's most people spend a lot of time. And when you're sick and not feeling well, or you're scared, or you're there with family members, you try to be an advocate for yourself, but you don't necessarily understand the system. You really need someone to hold your hand. You really need kind of insider knowledge, so to speak. And I think that that's at the heart of what we're doing, which is if you had if you had an ER doctor friend or neighbor who could come sit with you in the ER and help translate what was going on around here, verbally, that'd be pretty valuable. But we tried to do that digitally.
All right, sounds good. And then what other areas of the hospital that you're in? You said you're in the ER, the hospital uses you during the inpatient stay. What about the rest of the outpatient world? Are you there too, or are you pretty much within the sort of when someone's getting care?
Primarily in the acute care setting, we have started to work in the urgent care space as well. And then we also do help patients navigate their post-discharge life cycle, I guess, if you want to call it, the follow-up process, picking up their meds and things like that. So we really see the acute care visit as the start of the time we talk to patients, and then we follow them through their whole stay and then after it.
All right. So we'll talk a bit about how patient information and patient communication is going, because that is a world that's definitely changing, and there are obviously a lot of people coming at that from multiple different areas and lots of
Yeah.
different organizations, all who think they are delivering patient-centered care and may or may not be. But let's dive in and see what the actual experience is like using Vital. So what you're going to show me here is that we're going to see somebody who's just showed up at the emergency room.
Yeah. I can pull up the demo system. All right. So if you
So let's
let's
just to check. This is a demo system, but it's a system that's in use in a bunch of hospitals.
Yeah, so it's in a bunch of hospitals. We're in over 20 health systems and about 100.
This isn't something you just coded in Figma yesterday. Okay.
No,
Just to
no,
confirm. All
no.
right, all
This
right, all right.
is
So we're in the hospital. We I just shown at the hospital, and
Yes, this is not vaporware. This is
yeah, yeah.
real
I was
weed.
just doing the and I guess I showed up and they asked me my phone number as part of the intake process. You sit down and fill in a form usually,
Yeah.
or sometimes now
So
you're filling in a kiosk, right?
we have a different intake process than other health technology companies that you've probably seen. So we don't do username passwords. We don't do downloads. We don't do kiosks or iPads or any of that stuff. So we do things a little differently. It's all bring your own device, meaning, I mean, this day and age, almost everyone has a
Yep.
smartphone, and we use that. So, in order for you to use our system, you have to register, you have to show your ID, you have to prove to a human being that you are Matthew Holt and that you are checking into the emergency department. After that point, you have an encounter created in the electronic health record. Our software is SaaS that we sell to hospitals, but it is attached to the hospital's electronic health record, whether it's Epic, Cerner, Meditech, Allscripts. And once we get a signal that a patient has registered and created a new encounter, we will reach out to that patient on their cell phone that they gave during the registration process and invite them to use Vital. It's a white labeled solution, so it comes across to the patient as if it was a most of the time patients say, "Oh, this is a cool new patient portal thing," or whatever, but effectively it's something from the hospital.
Right.
So it would say something like, you get a this text message that'll say, "Welcome to whatever your hospital that you're at is." And then under that it would say, "Matthew, you want to know how long you'll be waiting for treatment and see your wait times and lab results. Click here." It's kind of like a password reset link, and that brings you into the system. Um, no downloading, no Wi-Fi, no username and password. We're two-factor authenticating you in real life by checking your ID and having a person create an encounter for you. After that, you put your last name and date of birth in to get in the system. It is multilingual, depending on the prevalence of languages in the hospital's catchment area. We translate it for them. It is also translated automatically into their browser's language of preference. So if you are Spanish speaking, you probably go on the internet in Spanish, and this whole screen will be in Spanish for you automatically. That's it. So you can get into the web application with your last name and date of birth after you're registered in the hospital. And we take you through the process of the emergency department based on the information we are receiving from the electronic health record. So if you check in, you walk in the front door, you register at the desk, and you have not been triaged yet, you would see this landing screen. Whereas if you came in by ambulance and you were rushed back to a regular hospital bed in the ER, you might see a different screen that's further along in the journey. So the only thing that staff need to do for Vital is get your cell phone number. After that, it's very hands off. It's very patient facing only. Although there are a few features that staff can work with, and
And,
I
it,
can
and
show.
it's just driven by changes to the EMR, basically.
Yeah, we pick up on signals that happen in the
Yep.
electronic health record and try and help patients understand that those things have happened and what they mean to them. So in this case, the patient's waiting to be seen by a triage nurse. We use complicated machine learning model to calculate wait times for all the different steps in the ER. And we do the same thing after triage to tell a patient how long they'll be in the waiting room if they haven't been brought back directly to a room. We provide information about how busy the ER is. This is to help the staff out. Actually, almost everything in here is to help the staff out. You're giving patients information that normally they would walk up to the desk and ask for or yell at you about.
They would
And
stop some, poor staff member from playing Farmville or whatever that. Well, I guess not playing Farm. They don't play Farmville anymore, but whatever the bits out of what the equivalent is, or actually doing some work. You never know.
yeah, we had a registration staff member in my old ED before I moved tell me that it was eerily quiet out here, which is not a word we use lightly in the emergency department for those of you that work in emergency medicine. So for her
Super.
to say that, I was like, okay, this thing is working. It means it's cutting down on the number of times people come up to the desk. Contextually, for those of you that have never worked in the ER, working in the triage desk, the check-in desk in an emergency department is like when there is a serious storm that takes out all travel at Hartsfield Jackson and people are lined up at the customer service desk at Delta. like trying to change their flights. It's like that, but 24/7 all day long, and even angrier because people are not missing flights. They're worried that they're having a heart attack, right? So it's not an easy place to work. So anything you can do to improve the quality of life for those people will make it makes a world of difference. So anyway, so that's what this thing does. It provides some estimates for patients who are waiting to be seen about how long it's going to take. We have educational content in here about, like what is emergency room triage, like why am I being prioritized differently than somebody else who checked in after me, et cetera, et cetera. We'll tell people who's on their care team if somebody signed up for them. We have information from the hospital, so this is all customized. Sometimes hospitals put, sort of welcome videos from the CEO or CNO or something like that in here, and then all the other things like that. If a patient gets triaged, we know that's happened in the EHR, so we move them forward in their experience automatically. If they get triaged and they get moved back to the waiting room, and we know they're going to wait out there for a little amount of time, the thing that they're going to care about the most is like, how long do I have to sit out here till I get seen? And so we've spent years, literally years, creating machine learning models that calculate wait times in the emergency room. And that's what will show a patient front and center. I could talk about this for quite a while, but suffice to say, it's kind of like Google Maps. So Google Maps knows how long it takes you to drive to work in the morning. It knows that the few cars ahead of you have taken longer than expected on the same route, and so it will lengthen your estimate. It's a machine learning model that's benchmarked in queuing theory, where we look at velocity through the department rather than sort of like what's the average wait time on this day of the week for the last 10 years. We don't do it like that. Ours is more
As
like,
a patient, you don't have to understand queuing theory and operations research to do this. You can just look at the number, I guess. I
yeah,
assume
you
it's
look at
about
the
right.
number. The number is we try to Disneyfy it.
Yeah.
The actual estimate's 40 minutes, and the upper bound of the confidence interval of the estimate is the 1 hour you see on the right. So in real life, 92 to 94% of all patients fall within the confines of this estimate, which is pretty good in the ER, where
Yeah.
if you've worked in the ER, again, there are a lot of people that just like wander out of the waiting room. You don't know where they went. They went outside to smoke or who knows. Like, there's a lot of chaos out there, but we get it right almost all the time. So we know a person's waiting. We have different types of types of why do I have to wait so long in the emergency room type videos that help explain things. Again, care team information. And as people proceed through this process, they're going to have access to more stuff, depending on the context of that part of their visit. So while you're waiting, you may not have a lot of tests and results back yet, but once you get into a room, you will. And so we're gonna give you more information about that then. Let's say you wait, 2 hours or an hour and a half, and the ER is like, that's just crazy. We need to reach out to these people. We'll do it proactively. Whether or not you've logged into Vital, we will reach out to a person's phone number and apologize for the department, tell people not to leave. What this does is it keeps people sort of actively involved, and it sort of does proactive service recovery. And what that results in is a decrease in left without being seen or left without treatment complete. It's actually really important it's important financially that those people don't leave because it's, from a business standpoint, not great, but it's also great from a medical legal standpoint. Like the patients that come in and check in and then leave you have a lot of liability around them. So it tends to be a key business metric for many hospital emergency departments, and we really do have a strong impact on it. All right, so let's say you make it through the waiting room process in this day and age, and you have made it to a hospital bed, and you are ready to be taken care of by a doctor. We'll tell you about how long it's going to take for the care team member to get in the room. We try to be fairly generic about who we promise is going to come see you. We don't say doctor or PA, NP. We tend to be fairly generic about how we describe things. We'll tell you kind of how it works or like what to expect as a patient in the emergency department. Like what would I, as an ER doctor, want you to know about what's about to happen? Trying to keep you focused while also figuring out kind of what your emergency is. We'll tell you who's on your care team. We'll kind of show you some progress in the visit. And here's where the app really starts to have some cool features. Although some of these are available earlier if these things happen. We do things like family sharing. This is extremely popular. So just broadly speaking, about two-thirds on average of all ER patients are going to use Vital when they're in the ER for something or other. And about a third of all the people who come through the ER will also use this family sharing. So if you click the family sharing in various places in the app, it'll bring up the system share dialog in your phone, the text message thing, and you pick someone you want to send a text message to keep you updated. We'll write the text message for you in the app. You hit send, and that person at home can follow along with your progress in the emergency department very simply. This is something we built during COVID because I was spending half of my shifts on the phone, kind of keeping people's family members updated as to where they were. And it's honestly, it's just been really nice to have this feature in the EDs where I work. And the patients love it.
Sure.
We also explain to patients their test results. So let's get into that a little bit. A lot of patients, well, let's say a lot, some patients will use their patient portal while they're in the emergency department in hospital. It tends to be about 10 to 12% of patients. And these are patients that are already members of your health system that already have a MyChart account or a Cerner portal account. But that's not the average emergency medicine or hospitalized patient. A lot of patients who come to the ER don't have a PCP in your health system, are new patients, or new medical problems, or they're not established, or they're too sick to bother to log in and figure out what their username and password was, whatever it was 10 years ago when they signed up for it. So we tend to get a large proportion of patients using this. And to that extent, we feel that it's responsible of us to help them patients understand their results. In a patient portal, you would just get results, sort of thrown at you. In this case, we will take things like, oh, you have a complete blood count. It's a multi-component test, right? So we'll take that test. We'll show you a video about what a complete blood count is if you need to learn, and some content about it. We will also break the components down into high, medium, low, depending on how the lab spits out the results. And then we will also explain to you what those tests mean right then and there. So you don't need to take your result and then go out to Dr. Google or ChatGPT and say, what does a white blood cell count of 11.4 mean? We will just go ahead and tell you. So it keeps everybody in the same ecosystem in a controlled, sort of approved environment.
So basically, if you're in the ER, you've gone to treatment, somebody came in, they ordered an X-ray, ordered a test, someone else came in, drew blood, whatever. You're sitting around waiting for the test to come back, and then when it comes back, it's explained here, kind of before or at the same time as when the team come back.
Yeah. And not only that, we'll tell you what tests were ordered. I mean, believe it or not, that's a big problem in the ER. Is like we put a patient in a room, we draw 8 vials of blood out of their arm, and then walk out of there without telling them what we were doing.
Sure.
And so we'll tell them in here if it's ordered or in progress or resulted.
Okay.
I would say the biggest ticket item for patients that come to the emergency department and the most expensive and concerning is always imaging.
Yeah.
It's not, I mean, it's fairly common nowadays, of course, in the emergency room, but it requires a different way of explaining things. So I'm going to get into that a little bit. If you go, let's say you had an x-ray of your ankle in the hospital, and you were one of the enterprising tech-savvy patients that remembered your MyChart login and you could get in there and read the note once it's finalized, you might see something that looks like this. We will show this in our application too. It is not something I would expect a patient to understand. It is something that historically a doctor would have to sit down with you and explain. We felt that that wasn't good enough, and we wanted patients to be able to have the tools to make sense of their notes and results simultaneously. So we use large language models and different AI models for note parsing to help patients make sense of things. We call this a doctor to patient translator colloquially, but it's effectively rewriting your radiology reports so that you as a patient can understand it.
Even some doctors might understand it at that point.
Helps me. Yeah, it does
Again,
help me.
right?
I'm gonna be honest with you. Yeah, I mean, sometimes you get these reports and you're like, oh, this is kind of a vague, rare finding. And, it is kind of a nice tool for me too, actually. So I'll sit down with, typically the way it works for me is I will go into the room, I'll ask the patient, like, hey, did you get this thing on your phone? Um, if they say, yeah, and then I'll say, let me see it. And I'm like, all right, let's look at this together. And I'll say, like, does this make sense to you? Do you need help understanding this? But the nice thing about this, I'm going to be honest with you, is that it takes the patients from like zero knowledge, it takes them up to like 3 out of 10 or 5 out of 10. And then I get in the room and I'm like, all right, let's go from 5 out of 10 to 10, which is basically like, there's a nuanced thing I need to talk to you about. and I can spend more time talking to you about what this means. It means that you're going to need to have an operation on your messed up ankle, and you're going to need to stay in the hospital for this, which is what the patient really cares about, rather than me coming in the room and saying, "All right, have you looked at your X-ray results? No, okay, well, I have some bad news. You got blah blah blah." Right? So,
Right.
it's just a better, higher fidelity conversation that we have when they're using it. It's really nice. Okay. So, as a patient goes through the visit, there are a number of other things they can do in this application. I won't spend a ton on time on them, but they tend to fall in this sort of like administrative category. So, we will have patients use their wait time as productive time so they can correct their information. We have some surveying capacity in here where we can do real-time service recovery or staff accolades. We have tips to decrease left without being seen. We decrease length of stay by talking to patients about certain things like how are you getting home? You should start thinking about that now before the end of the visit. Um, there's like even basic things that you wouldn't think. Patients actually spend a lot of time in here. So we're like, okay, I do need to get my med list ready before I get into the room. Or, by the way, did you know the thing that explains the most variability in estimating the length of stay in the emergency department visit is time to urine collection and result? It's not CT scans, lab results, assessments, or anything.
Really?
Urine testing. Ask any ER person what's the most vexing part of their day, and it's trying to get urine out of patients who just went to the bathroom. Yeah, you want to talk about chaos theory? It's encapsulated in urinalysis in the emergency department. So just doing these basic things, we could decrease length of stay. Most of our users have a diminished length of stay compared to non-users in the application. So it is helping out, sort of grease the wheels of the machinery of the emergency department. So we're decreasing length of stay. We are decreasing left without being seen. We're decreasing staff complaints, improving Google scores, and all the things that you would expect when you communicate with people better. So that's how it works in a nutshell. There are some other cool features, like we have a YouTube-esque video education system that is not governed by staff. It's queued on by sort of diagnostic codes and procedural codes and reasons for visit and things like that. To be honest with you, there are almost no educational systems in the emergency department. They tend to be more geared towards inpatient setting and outpatient setting, and the ER patients really need it. And the only way to really do it is to make it so that the ER staff aren't like feeding and watering it, right? It
Right.
has to be something somewhat hands off. We have a request system where patients, this is something staff have to do, but it's optional, so they can turn it on and off, and this button goes away. But if a patient wants something, they can click a button and say, I need to talk to somebody. It works in the waiting room in a hall spot. It's very popular for patients who are boarding, and it really solves that sort of like, what's going on around here problem because it lets staff members come and like provide them with service. So in this case, in this example, it was a patient with a bad ankle fracture. There are a couple things that can happen after you've been through this process. You can either be admitted, discharged, or transferred. Those are the three options at the end of an ER visit. And let's say you are discharged home. A patient will be told kind of how long it's going to be before you're discharged. And then after they're discharged, we do a number of things to ensure that they know what to do next. It's very simple. It's sort of like one page. Here's what you got to do after you leave the hospital today. Um, it's understand your care. So we will you again use LLMs to help patients make sense of their doctor notes and their discharge summary. We will tell them who to follow up with. So this person may have been listed in their discharge paperwork as the person to follow up with. We have a system that will suggest other doctors they can follow up with, based on the type of surgery they need or where they live, cost and quality data, which I can show you at the end of the inpatient experience.
I could definitely use that. The last time I went to the ER, they gave me an MRI. They came out. They said we've given you a referral, and I finally read my note and had the doctor's name and nothing else. And I had to go Google the doctor. And when I tried to call the doctor, of course, it wasn't his office. It was like some spine center asking me what kind of doctor I wanted. And they called me back in 3 days. It was this would have been
Yeah, I
better.
mean, the normal lived experience for patients is to receive a referral from your primary care doctor or a specialist, right, to see another specialist.
Yeah.
I mean, the majority of ER patients need a specialist. It's like 40 or 50% of post ER discharge. They've already been to the ER, they've had 6 months of medical testing performed in 6 hours. CAT scan, full set of labs, an MRI, et cetera, maybe even a consult. And what they need is a follow-up with a specialist. And the tricky thing about that is ER docs don't give referrals. We just tell you who to follow up with and usually
At least I think they gave me a name, which is probably a one up. Go and see a surgeon,
yeah,
that kind
so
of thing. Yeah.
here's how we solve that problem.
Yep.
So we will pull a name out of the medical chart. So like let's say you came in, you fell down and broke your wrist. Okay, you need a hand and wrist surgeon. In this case, Selena Schwartz is on call. She's the person that was recommended. She maybe even came to see you in the ER and said, "Hey, I want to see you in my clinic next week," right? We are going to pull her information, contact information. If the health system has self-scheduling set up through their electronic health record, that will be an option as a button on here too, or just the phone number. We will run your insurance against what she takes. We'll give you her cost and quality data. Now, if the ER doctor splints you himself, like if you came in and I fixed your arm and I said you need to go see a hand and wrist surgeon, I don't put her name in there. We're going to show you a bunch of hand and wrist surgeons that fall within the network, right? And we know not only that like there are lots of orthopedic surgeons, but not all of them do hand and wrist surgery, right? But we can see from our database what types of procedures this person does. So maybe it's not Selena Schwartz, it may be Teresa Webb or Brooklyn Simmons. That would be the ideal doctor for you. And you can kind of read through all their data. You can make that choice yourself. What it does is basically you could think of it like a lot of health systems have these like find a doc systems where they put every doctor in the whole world on there and you're like, there's like, 250 orthopedic surgeons in this health system. Like, who do I call? Well, you don't know which one of them do hand and wrist. You don't know which one take your insurance. You don't, et cetera, et cetera. So this will get you, it's a bit of a
Much
cold
closer.
start problem. Yeah. Yeah. We do the same thing for PCPs. A lot of patients, believe it or not, who come to the ER, only about 25% of them know who their PCP is. It's an
Surprised, not
astonishing.
surprised. 25% have a PCP. It's probably one the ER
Well,
hospital.
a lot of people on Medicare Advantage have a PCP. They may just not know it.
Well,
So we'll pull.
I'm in an HMO, which I have a PCP who is not my official PCP of record for some reason because I think he lives too far away. And they can I think they changed my PCP allegedly. We're sending me new cards 3 times in the last 12 months, and you know. I'm not surprised that people don't know who their official PCP is versus the one they actually see versus a lot of people just don't have one. Even if they
Yeah, I
are.
mean, I would definitely put you in the health literate category. And if it's confusing to you, I mean, imagine
Well, I
like,
mean, because you're probably if you're in an HMO, you're probably being sent down to an IPA, which has various medical groups within it, and then they'll allocate somebody close to you to that. I happen to be in one medical, which I know is in the HMO, but it's not in the HMO in my county.
ah,
So it is covered when I go to my PCP, but they whatever reason they cannot. I cannot attribute myself to the one medical doctor I go and see. It's bizarre, but anyway, but by the level of complexity behind that is I'm not surprised that most people are really stuck, and there
no.
are a lot of people who just don't have one and need one, right?
Yeah, absolutely. So we try and make it easy. I mean, it's not simple to get an appointment, but it is also not simple to even figure out who to call. And I mean, if you talk to health system marketing people, the conversion rate, so to speak, of people coming to their website to look for a doctor and clicking on it and making phone calls is horrible. It's like if you're lucky, 5%. Yeah, you don't want to run a business where only 5% of the people who come to you asking for a service are able to access that service. That's pretty bad, right? Not to mention, patients are spending 10, 20 different phone calls being on call, like waiting. So we try to cut out about half of that, at least half of that busy work and try to make it more likely that the patient's going to reach the
Right.
doctors that they need. And then just basic stuff, where were your drugs sent after your prescriptions? What were they? We spend a lot of time trying to get patients back into the portal or the health system record, right? So we know working in the hospital and in the ER with all these patients is that most of them don't have a portal account, that very few of them. And these are patients you don't want. I believe the business term leaking out of the health system, right? So from business standpoint, you want to keep them in your network, your hospital's network. You want to keep them coming back for further business at a later date. You definitely don't want that patient with a broken wrist leaving your health system and going to some random orthopedic surgeon outside of your health system. So the best way to do that is to keep talking to them, make it easy for them, and then have them use the other services, whether it's signing up for the portal, giving compliments to care team members, and things like that. So that's what we do. Part of our business model is that system loyalty. It's, I guess, to some extent, no different than the value proposition of applications like this in other industries, right? I mean, it's tremendously valuable to Delta, for example, to have an airline app that you use while you're flying and buying other products and stuff from them. Um, this is not exactly the same thing. We're not selling you things while you're in the hospital, but it is something that I truly believe is valuable to patients. And so because they find it valuable, we wind up with, 2/3 to 75 to 85% of all patients using it. And because of that, we're able to sort of create downstream loyalty to the brand of the health system and also, of course, follow-up appointments and other things like decreasing left without being seen in operational metrics that matter. So
So
that's what a
that's
discharged patient
yeah.
would experience.
And this is the one. Now we're going to see the one going into the hospital.
Yeah, I can show you that. So obviously not all patients are discharged. 85% of them are, but for the 15% that do stay in the hospital, on average, they would either continue in the same experience or if they were admitted from outside the hospital directly to a floor bed, let's say they were in a surgical center or something like that. Most people get admitted through the ER nowadays, but not all. It would log in a similar mechanism. And then when they're in the hospital, the feel is different, right? It's like, well, how do I describe the feeling of being in a hospital for anyone that's not been a patient in the hospital? It's like just so boring. And there's so much time where you're just sitting there like, what's going on around here? But on the flip side of it, as a doctor, a nurse, or whatever in the hospital, like you feel like you don't have any free time. Like I wish I had an extra few minutes to go talk to that patient, let them know what was going on, right? So there's a mismatch in terms of effort and expectation. And so what we try to do in that case for patients and their family members, so like once you're in the hospital, the utilization is just as high, but almost all those patients have someone also following along who's not there. So what, like for me, it would be family members inviting me as the family doctor, and they're in California and I'm watching what's happening, right? So what we're doing in this case, and this thing is great. It's basically a single screen where we would take all the digital information we can get out of the electronic health record and process it in a safe way and give it back to you as a patient so you understand what's going on around here in as much totality as we're able to give it to you. So it's all your notes, your orders, your results, everything from the history and physical documentation to consult notes to physical therapy notes to diet and things like that. And we are going to try and explain to you in a nutshell what is going on around here and let you have control over this information in terms of frequency of updating it. And we're going to take it one step further by suggesting to you things you could ask the doctor. So typically we will say generally what's wrong while you're here. This is a real example, by the way, of a patient that was admitted to the hospital with some what sounded like mesenteric thrombosis that they had to go to the OR for. It's explaining what that condition is to them in plain language. It's picking up things that are core foundational diagnostics, but also subsequent things, like, for example, monitoring your kidney function. In this case, the patient had an acute kidney injury from clots in addition to the mesenteric clots. There'll be pieces of the care plan for the day that are pulled out automatically. These are not things that people are writing. These are a combination of things we gather from orders and notes. So if a cardiologist sees you in the morning and says, I want an echocardiogram, that would be something that we'd be able to show the patient.
So and the patient already said, "Someone, hey, I'm supposed to get an echocardiogram today." The nurse
Well,
is
you'll
like,
see in there, it
"Hang on,
doesn't
yeah,
say like it's scheduled for 2 p.m. because you know
right,
how hospitals are. It's like
right."
could happen at any point today, but
You get to the end of the day, and it didn't happen. You go, "Hey, what happened?" Oh, yes, someone should read the note. There's an order for it. Yeah, I can see. Yeah,
yeah, but I mean, we should, like that's accountability that doesn't exist right now because patients can't see that stuff,
right,
right?
right.
Like the patients don't have the power to hold you as a doctor, a nurse, a tech, whoever accountable for the things you should be doing or that you said you were going to do in your notes, right? And I know that doesn't sound right, but like we really need to kind of flip this around and say like how can we get the patient involved in this? The only way to actually get the patient involved in this is if they understand how this is all happening behind the scenes and like how much detail there is to it. And by the way, patients like love this thing. They spend tons of time in it. I mean, an average patient in the ER spends about 30 to 35 minutes in the application during an average length of stay of 4 hours, 4 to 4.5 hours. So they're in this app all the time doing stuff, reading stuff. And the same thing's true in the inpatient setting. There's some different stuff in here, quality of life things for inpatient, which are not AI, advanced AI models. They're like, you can order your food in here and we will communicate that to the staff in the kitchen, and help you understand what you can and can't eat and whether or not why you can't eat after midnight and things like that. Like basic things that you would
Presumably,
expect.
you have to interface with the food system, which I guess is not part of Epic or Center.
Uh,
It's some other system, I guess. So,
That's right. I mean, like electronic health records are a mishmash of different software
right.
platforms that have been rebranded. And one of those things that hasn't really been rebranded yet is are the diet order systems. Like in the hospital, the people cooking food in the kitchen are not looking in Epic and everyone's chart, right? They're just getting orders off of phone calls and things like that. So they call this DoorDash for the hospital. We built this for. It's very popular. I think it's more popular amongst the people who cook the food than it is amongst the patients who order it on there. So it's cool. They can text bidirectionally. So if you order, like let's say you're on a like a pureed diet and you want to be funny and you type in like a hamburger, then the staff in the kitchen could be like, you can't have a hamburger. Like pick something else, things like that. So it's very popular. Um, I guess above and beyond that, there's some redundancy with the ER product because it's a unified experience. Really, it's like a whole platform for the acute care experience. So patients expect to see things that they saw in the ER. We have tests, learning items, all still present. Looks very similar. The requests are a little different in the inpatient setting. So in the ER, it's like I need to talk to someone. It could be one button in most cases, right? In the inpatient setting, our philosophy is keep all of the low level requests away from the nurses,
Right.
especially the nurses. Don't bother the nurses, right? And the doctors, but really just the nurses. And so anything we can route to a staff member who's not a nurse is a task that the nurse doesn't have to do. It's a medicine they could administer, a double check on vitals. It's all the other things that you need.
Sure.
So we route all these things to the right person in the hospital. It's a completely configurable
Bedding
list.
and toilet paper and temperature and all that stuff.
Yeah, like some hospitals, like for example, they may have like pet therapists that can come around and visit. You can click the button. I call that the Paw Patrol button. It's basically like you can, depending on when they're available, the button will be visible to the patient and so on and so forth. So that's how that works. I won't dive too much into the staff part of the system, but it's very simple. You just log in on a smart device or like a browser on your virtual desktop or in the electronic health record itself, whatever's easiest for your facility. So, other than that, you're going to have the same access to results, education that I showed you earlier. Um, there are there are surveys that we do during the visit, to help people understand kind of what's going on. I'll show you one. This is the one from the ER. So we do
Just to
spot
go
survey.
back a second, just in that previous screen,
Yeah,
it's populating. The stuff at the bottom there. If you scroll down, the latest for you is populating as it goes. So presumably
yeah,
that changes that stuff on a
yeah. It's
daily
cool.
basis, hourly
Yeah.
basis, whenever something new tests come in or whatever.
Correct. All of the above.
Right.
So yeah, so it tends to be, hey, like the newest thing that's happened to you is vitals, X-ray, things like that. So
Right. Okay.
yeah, it's very I hope that when you see this, you'll get the feeling that you're looking at normal consumer grade software like you would expect in any other industry, because that's how we've sort of designed it. It's a very different experience than it's intuitive, it's sort of anticipatory and things like that. So I hope that that comes across as you
Right.
see
No,
this.
I think so. Yeah.
So I guess the last thing I'd like to show you is that we have a survey mechanism. So we do pride ourselves on doing real-time service recovery, assistance with patients, and then also staff accolades. So if you ask a patient how's it going in the hospital, by text message, depending on what's happening with them, whether it's after they've been seen in the ER or after they've gotten back from an MRI, you can really figure out kind of how your hospital's working. But the only way to figure that out is to ask them in flight, rather than 3 days later when you get an HCAP survey and you're trying to infer, kind of what element of the totality of a patient's care led to their bad experience, right? You don't want to be doing that. So what you do is you ask them while they're there, and the simple survey, good, bad, ugly. If it's ugly, you ask them why, take them through this process, and then you escalate it to a staff member that can go to the room and talk to them. That's it. Simple. We've seen dramatic improvements in HCAP survey scores when you do this. We've seen people turn from low to high almost immediately just by that recognition. And vice versa, if your patients are happy, right? You can route that to people that don't usually get positive feedback, like ER staff members. So, like I don't know if you know any ER nurses, ask them when the last time they got positive
A
feedback from a
compliment from
patient.
anybody. Yeah. Could be a
ER
while.
doctors too. I mean, it tends to be. And I'm not making a joke about how bad care is in the ER. What I mean is like it's just so hard to get positive reinforcement in the hospital to one person because it's like it's a care team, everybody's involved. If one person's mean to the patient, then it seems like everyone's mean. But if somebody's really exemplary, you want to compliment them right then and there to reinforce that behavior and to make them look good amongst their staff members. And so we do that. I can guarantee fix the Google review problem in your hospital. So the average Google reviews in our emergency departments go up by 1 point within a couple months. The average emergency department has a Google score of 2.3. So you do the math. Some of our ERs are now in the 4.5, 4.7 range because we are essentially
Exceptional
taking,
for healthcare, right? Most healthcare,
uh,
2.3
yeah,
is quite a good rating for the average healthcare organization.
well, yeah, I mean, most hospitals actually have a different, so, Google ratings are based on the map locations, and actually Google separates the hospital from the emergency department. So, if you look in your hospital, for example, or whichever one you go to or work at, there'll be two different Google scores, one for the emergency room and one for the hospital. And so, there's no patients have some sort of life-threatening emergency and then they go to Hospital Compare or some website like, what's the HCAP score for patient communication at this hospital, right? They're going to Google Maps saying, where's the nearest emergency room? And they're trying to figure out which is the one that has the best scores, right? That's it. That's what I would do. It's what most consumers would do. And so in this era, your digital presence, your digital reputation is increasingly about Google. Now, it doesn't mean that doesn't mean that that's the only thing the hospital should care about from quality improvement and patient experience scores and all those things that are mandated by CMS, but they're just not things that patients care about, right? So if you want patients to recognize the good care that you're giving, you have to get that care recognized and put out into the public sphere. So we do a lot of that and really help hospitals with their reputation. So that's about it. I mean, there's more to the application. I can answer any questions you
Oh,
have,
well,
but I
no,
think,
that's great. Why don't you kill the sharing, and we'll talk a bit more about sort of the
yeah.
impact you're having. So you along the way you talked some about the impact, right? So impact in basically improving the patient experience and improving the staff experience by taking a lot of the sort of
Yeah.
uncertain patients. And I think a lot of this is about resolving consumer uncertainty or resolving people's uncertainty, and you know, I often talk my Mike McGee, who is on TV quite a lot, he often says that the job of a doctor is to assuage fear and worry. That's what your job is, right? And a lot of this is the uncertainty. You're sitting there, you're in pain, you have something going wrong, you don't know what the hell is happening next, and it takes a long time before you don't even know. You may be pushy like me and say I came here because I wanted to get an MRI, as opposed to someone saying, well, we're not sure what we can do with you next, and most people I think don't know. They don't understand their test. They don't understand the drugs they're on. They're really concerned. And then that's right. The room was cold or whatever, and I wanted to deal with it. And I think a lot
Yeah.
of that just it doesn't get done. So let's talk about the sort of state of play of within the ER and within the inpatient piece. Obviously, there are people who are pulling out their My Chart portal, which
Hmm.
has its moments. I keep on trying to get an appointment on mine. The last I tried to get a radiology appointment, the only one who would offer me locally via UCSF is a mammogram, which is probably the only one I don't need. So there are things that you can and can't do. But in terms of the hospitals that you're in, you're talking about pretty high percentage use in that. How would, for big health systems, when you got to try and sell this stuff, does it tend to be that they'll buy it enterprise system wide, or do you have to go in sort of block by block and fight by ER and convince the lower level staff to get this? Or is there kind of more a sort of system wide understanding that we've got to do something about our experience across our 5, 10, 15, 30 hospitals, whatever it is?
I mean, that's an awesome question. I think that if you asked anyone in the health tech SaaS space where they're selling to IDNs or large health systems, they would all say, yes, I have an enterprise solution. I'm walking in and cutting a deal across all of the emergency departments. And we have gotten to that space now. So we're starting to do that as a company. We have a few large contracts. But historically, we would, when we were smaller and we didn't have as large of a customer base. I mean, we're probably about 150 hospitals by the end of the year, maybe more, and over 20 health systems. And when we were smaller, especially in the post-pandemic period when everyone was scared about everything, we might come in and do one emergency room and prove value, and then it would expand out to other emergency rooms. We built the inpatient product after the ER one. So we built the ER one first, probably because I'm an ER doctor, but also because when Aaron and I were sitting around ideating on this, we thought, all right, we're going to try and fix patient communication in the hospital or in healthcare in general. Where's the area of maximum entropy where we can use new tools, AI, natural language processing the best? I was like, I know where there's some problems. I can find that place. I know where that place is.
What do they tell authors? Write about what you know.
Yeah, no, it's exactly.
Our docs becoming software execs. Yes, right. Fix what you know about.
That's exactly right. We're all trying to get back to Indianapolis.
It's getting there system wide. I mean, do you think the C-suites of the system, not just the individual hospital, or not just the ER docs, are recognizing that this kind of consumer retention, consumer storage, consumer experience is now a big deal? It's on their radar.
Absolutely. Yeah, I mean, I have also I've also witnessed an evolution in the way that the C-suites, the CFOs, CTOs think about software investments over the last 10 years. I mean, we have all seen the market shift in EHRs and things like that, but um, you know, you hear a lot of people say that health systems don't want to invest in point solutions. They want to invest in EHRs, or they want to invest in whole enterprise-wide solutions that solve all their problems in one place for the sake of parsimony. Frankly, you talk to most CTOs and they're like, I got 1,200 pieces of software bolted onto my EHR and like it's just too chaotic and it's too risky. And I totally understand that. So to that extent, we try and have been lately selling our software to whole systems solutions for throughout the acute care experience whenever possible. So I don't know if I've answered your question exactly.
Yeah, no, I think it makes sense, and and I think that there's a question which no one knows the answer to yet, which is does the next generation of sort of AI tools, and you've got someone obviously built in to what you're doing, does it go to the point where where one AI tool can basically read into the EMR, read into whatever the database is, and the lab system or whatever, and figure out whatever happens to happen next. And there's a ton of things that happen next, some of them for patients, some of them for doctors, some of them for admin, some of them for billing, all the rest of it. And I think you've got some of these companies who are raising a gazillion dollars, like the ambient scribes, or some of the sort of some of the interface systems, the interfaces of the world, and the commuters and the ambients and the bridges, who are kind of going, okay, well, now we've got our finger in one pie, we've got to stick our finger in seven or eight pies. And there's a natural my commentary, there's a natural tendency for them to go, that's a great idea, but by the way, if somebody's doing one thing really well, like we're managing the patient experience in the ER and the acute setting, is likely to do something much better. And by the way, probably can go in and grab the same data. And some of that comes down to the technical question of, does the CTO have to build another interface? And if the answer is you've kind of built it for them, or the APIs are there and they're surfaced, it's probably not as hard. And I honestly think that most hospitals are now sort of seem to be jumping in and trying a bunch of this different stuff. They're also building, the bigger ones are building all the stuff internally. You see Stanford keeps on coming out with a new thing that they built using Anthropic, every couple of months. And I think that will continue to play on. But I think for now, the business people are going, we have a problem in various areas. We have to fix it, which is probably why you've, seen the growth you had. So if you were to take a different slant, you said you have 20 systems, 150 hospitals. There's what, 150 big systems in the country, 150 systems of some description in the country, and probably more. How many of them have got something like you or something like a competitor? I mean, how much greenfield is there, and how much are you doing? Five people who are kind of doing this already.
To be perfectly honest with you, I haven't seen anyone else doing exactly or even similar to this. They tend to be,
I mean, there are people with kind of intake systems like Schrager.
Yep. Yeah, there are people
there are a bunch of pieces that are somewhat got some of this somewhere. You can imagine could expand your direction. You have people who are trying to do patient messaging across their journey, like
care coordination type stuff. Yeah. I would say that in this to do this well, to help patients understand what's going on in their care, you have to be deeply integrated in the electronic health record. And the vast majority of companies that are doing this are kind of like nipping around the edges of it, right? So they're going to one specific area, whether it's oncology, coordination, things like that, and or leveraging the lack of data that they're receiving by forcing people to do things, right? So like we know it may be triggered off a simple ADT connection, but we're going to make the nurse in the clinic program this pathway for breast cancer, et cetera, et cetera. And that may be a wonderful tool. It's not really the space we're in, right? We're not in the pure customization space. In fact, I never want my software to create one more thing for staff members to do unless they literally ask me 3 times and say, I really want you to put a button in here to tell me to go talk to the patient, right? Which is why we have that button in our app.
Right.
So we don't do extremely complicated, bespoke care pathway type work, even though I think it's extremely important. But I'd say that there have been a few companies that have touched in the acute care space in the past. There was a company called Ease that was acquired by Stryker. They did OR-based communication. It was extremely staff intensive. Like staff had to have iPads and take pictures and stuff like that. I'm not sure if they are around anymore, but I kind of liked what they were doing. It's sort of the opposite of what we do. But it was sort of in-flight communication, which I think is really important in the acute care setting. And then, of course, there's MyChart Bedside, which is a platform that some hospitals have tried to use to help patients understand what's going on with their care in the hospital. And I won't say anything more about that, but that's a thing that exists.
I mean, there is the constant fear is, I know it's the old Microsoft FUD, fear, uncertainty, and doubt. Epic is now talking about, oh, we're gonna do all these different things, and we're gonna use AI to do everything. And I'm still not sure about, they've partnered with specific companies around AI. They obviously have this big relationship with Microsoft. They have, they're talking about all the things they're going to do. And I think half of healthcare is hoping that half of hospitals are hoping that Epic will just build all these products and don't have to worry about anything else. And the other half is going, oh, we know they're never going to do that, or the thing they're going to build is going to be any good, So,
yeah, I mean, that's true. But, at the end of the day, I wouldn't say that we are competing with Epic, but there's a reason why, Microsoft Teams has 20 times the users that Slack does, right? It's sort of this sunk cost fallacy, and it's not a better product, but it's free, it's already there,
it's already there, and
yeah.
We'll see how that goes. And I think there's that whole Epic's entire thing, which keeps on changing its name. It used to be App Orchard, and it became Marketplace. Now it's Workshop, and there are different levels of partnerships and all this kind of stuff. I mean, there are very few people. There's Brendan Keeler and about 3 other people can keep up with it and figure out what's actually going on in that. But they're clearly, they are sitting there in such a big monopolistic position. They also have to be worried about that position, right? Because given how much progress they've made, and in the last few years how the few big competitors to them have got out. Basically they'd be, people like UPMC and Intermountain who had other alternatives are now all gone to them as well. It's, they have to be careful about what they're doing, and they traditionally have been quite aggressive about where they've gone, and they have to think about the companies. But to me, there are still more and more people trying to sell into hospital systems of different flavors of technology, and there's a bunch of stuff that needs to be fixed that could be done with software, and it's just the job of the hospital to figure it out, especially, and that's just within the hospital. And then you start thinking about all the linkages they're doing out to people like me, discharged and unable to figure out where they how to get an appointment with a specialist. I just did a video about this a few days ago about being discharged from, well, not being discharged, but being going to having a primary care visit and trying to find a dermatologist, within the Blue Shield network, and that's still a mess that someone needs to fix. But anyway, now we're getting way off topic.
That's the golden goose of access and appointments and all that. That's the golden goose. But yeah, I think what I've encountered talking to lots of different health systems around the country of different sizes, that whether they're on Epic, Cerner, Meditech, whatever, is that there are always people looking for a way to do better, and especially in some competitive markets, to look better than their competitors, but just in general trying to achieve excellence. And so it's a nice thing to be able to deliver a solution that, in my opinion, really puts the patient first, right? It's like, I think that the reason we're able to get the results that we have with regard to follow-up revenue, that's one of the things that health systems like brand loyalty, decrease operational sort of problems like left without being seen and whatnot, is because we're like giving the patient something they want.
Right.
We're not just like texting them and saying like, hey, we don't want you to leave the ER, please don't leave the ER, right? We don't do that. We say, hey, what do you want to know? It's your wait times, your lab results. You want to help understand it. So, I'm proud of what we built, and my team is like very innovative, creative group. So they're very dedicated to what we're working on, and I think it's a cool solution. So,
right. Let's end with just sort of quick wrap up of the company. You're how many people?
we have about 48, I think, as of today.
Say around 50. And you raised how much over? And when was the last time you raised?
We went through a B, and that was a few years ago. So
A couple of years back. So
yeah.
And then the obvious question is, what else do you have to add to this, or do you have to figure out a place to go live as a venture back company? What I mean, there are other areas that you're probably have to expand into, and obviously you said you sold to 20 health systems. I think there's another 100 you can go sell to, so you have some work to do there. But
Yeah.
what do you think the next sort of steps for the company are?
Oh man, there are so many things we could do. I think we have I won't say who it is, but one of our brilliant venture capital investors said, companies like yours don't die of starvation, you die of indigestion after the buffet. And I think
Right.
it's true. It's like where shouldn't we go is probably the best answer there. I
Yeah.
mean, if you it's probably the same question that all the, or at least moderately or very successful ambient scribe companies have, which is like, we have the tech, we have the access, we have people's attention now for once in the last 5 years, right? And where could we go? And what my heart tells me to do is to go towards the patients. So away from billing, not that that's a bad thing necessarily, but one of the things we always put in front of our ideas is this thing in the best interest of the patient, or is it just something the hospital is asking us to do? So my suspicion is that we're going to go more towards personalization of the visit. So it's not just how long you're waiting, your lab results, help you understand your lab results. It's actually get to know you, Matthew Holt. Like, I need to know what makes you tick. I need to help the doctors help you by helping with that bidirectional communication. That's my guess. And then we're gonna probably from there get into all the things that interpersonal interactions can affect in healthcare. I mean, it's all I want to just bucket in an SDOH. It's all the out of the hospital stuff that really matters in terms of healing. So
Well,
it's
there's
that
a
kind of stuff.
ton you could do there. There's a ton in the sort of outpatient world. There's a ton in the outpatient referral world. I mean, yeah, and as you said, but on the other hand, as a company that's relatively small, you have to focus on, there are the other 100 systems we haven't sold it to yet. So probably should go do that first.
Well, yeah, of course I want to sell. I want to sell the software to as many health systems as possible, so I can keep working on it and building it. But I think, we're always building, so we're a very product heavy company. So yeah, we don't lack for ideas. It's more just time.
That's great. Well, that's a good place to be. All right. I've been talking with Justin Schrager. He is the Chief Medical Officer of vital.io. You'll find him on the web. And hopefully you've sat through this, you've got a pretty good idea of how they're improving the patient experience. And something that I've been saying for at least 25 years is a good idea. We should be improving the patient experience. Justin, thanks for your time. Thanks for coming on and showing us the
Thanks, Matthew. I appreciate it.